So this afternoon, we are going to look at the integument system, and we're also going to look at mechanisms of thermoregulation. I prefer giving this lecture in 3 parts. The first part, we'll talk about microscopic organization of the skin and its appendages. On the second part, we talk about behavioral mechanisms and physiological mechanisms of thermoregulation. And in the third part, we talk about development and congenital anomalies of the skin and its appendages. So let's start with the first part, which is focusing on microscopic organization of the skin and its appendages. In this part, we are going to look at the components of the integument system. We are also going to look at the functions of the skin. Just a second. Okay, apart from functions of the skin, we look at the general structure of the skin. We look at histological structure and cell types of the epidermis. We look at the histological structures and components of the epidermis. And finally, we look at the organization of some glands which are found in the integument system, namely skin, sebaceous glands, and mammary glands. Let's start with the first aspect, which is the integument system components. When we talk of integument system, we are referring to the skin and its appendages. And when we talk of appendages of the skin, we are referring to anything that is attached to the skin. So hair, nails, and glands are part of skin appendages. And the glands which are part of skin appendages are these ones: sweat glands, sebaceous glands, and the breast, which we call mammary glands. So what are the key functions of the skin? We can say that the skin has the following functions. The skin protects against many things. It protects against physical injury, usually because of the keratin lining of the epidermis. It's able to protect the underlying tissues against physical injury. It is also able to protect against ultraviolet radiation. And this is courtesy of the melanin pigment, which is in the skin, that absorbs ultraviolet radiation. The skin protects against infections by just forming that anatomical barrier to infection, or by the cells which are on the epidermis, which help to fight infections. The skin is able to protect against infection. And it's for this reason that when there is a wound, then you are likely to get an infection. And that's why sometimes you use antibiotics then to cover for that. And importantly also, skin help to protect against loss of body water. It is for this reason that if a patient gets burnt, then one of the management strategies is actually to protect against fluid loss, either by rehydration, for example, so that you just replace whatever has been lost. We know that fluid loss is one of the things that we really must watch in a patient who has suffered burns if you want to protect life. That you're never really worried about infection on the first day. You're never really worried about the complications of it, but fluid loss is an acute phenomenon that you have to address. The skin is also a sensory organ. This is because it houses several sensory receptors. Receptors for touch, receptors for pain, receptors for temperature, receptors for vibration, and many other receptors that we talked about when you looked at sensory system. I hope you remember the definition of a sensory organ, sensory receptor, and sensation. So skin qualifies to be called a sensory organ because it houses sensory receptors. The skin is also important for excretion of waste products. These waste products are excreted through sweat. So maybe excess salts and maybe urea are excreted through skin, through sweat. Ever wondered why when it is too hot, you urinate less? Okay, partly because of fluid balance, but also that remember that there will be a lot of waste products that will have already been excreted through the sweat. So you'll urinate less. But when it's too cold, you produce a lot of urine actually, because there is less sweating. So most of the excretion is occurring through the kidney as opposed to through sweat. And perhaps you may know that if a patient has chronic renal failure, where they're unable to excrete a lot of substances through the kidney, and namely urea, for example, the skin might take over that role because of the high levels of urea in the circulation. The sweat glands will be releasing a lot of urea through sweat because now the urea cannot exit through urine. And so in patients with chronic renal failure, we see a lot of excretion of urea through sweat to the level that this urea can actually form crystals on the skin, what is very pathognomonic of a patient with chronic renal failure, what we call uremic frost. Skin is involved in the metabolism of vitamin D. You may not know that we take vitamin D in form of its inactive metabolites. It can be usually through diet, but the dietary component of vitamin D is not the major source of vitamin D. The major source of vitamin D is that these metabolites, these inactive metabolites, are actually synthesized through the action of light on the skin. And so the metabolites of vitamin D, precursors, come from the skin and go to the liver. Similar to the ones you take from the diet, they go to the liver. So whether from dietary source or from cutaneous source, they go to the liver. Then from the liver, they undergo some process that then give us some intermediate metabolites which go to the kidney. And then at the kidney, that's where the active form of vitamin D is obtained, what we call 1,23-dihydrocholecalciferol. So that's the active form of vitamin D. My point here is that for us to get that active form of vitamin D, at some point, skin has a role. And finally, we can say that skin has thermoregulatory functions. The skin is involved in various mechanisms that either conserve the heat that we already have if it is very cold, or help us to lose the heat that we have if it is very hot. And we are going to see those mechanisms. So what's the general structure of skin? Skin can be described to have two layers. The upper layer is called the epidermis, and this layer is consisting of epithelial tissue. So there's an epithelial layer. Then the lower layer is called the dermis, which is a connective tissue layer. Basically, those two layers are the layers of the skin. epidermis being epithelial and the dermis being connective tissue. There's a risk of these two layers to be easily separated, and to prevent that from happening, the two layers of the skin are anchored together by several interdigitations. There are projections of the dermis into the epidermis, and those projections of the dermis into the epidermis are known as the dermal papillae. You can call them papillary dermis. Similarly, there are projections of the epidermis into the dermis, and the projections of the epidermis into the dermis are known as epidermal pegs. You can call them epidermal ridges. So the epidermal pegs and the dermal papilla interdigitate to ensure that we have good anchorage between the epidermis and the dermis. And for that reason, therefore, it's not easy to peel off the epidermis from the dermis. There's a layer known as hypodermis, not quite a layer of the skin, but we like naming it together with this because this is the best time to talk about it. The epidermis is the layer of fat that is below the dermis of the skin. In gross anatomy, this is what you'd want to call the subcutaneous tissue. It is the hypodermis, layer of fat. Now, the amount of hypodermis varies between one individual and another one. Again, the amount of hypodermis varies within an individual. If you're a man, you know that the amount of hypodermis in your scrotum is very different compared to the amount of the hypodermis in the anterior abdominal wall. If you're a woman, again, you know that the amount of hypodermis on your gluteal region or on your thigh is very different from the amount of hypodermis, for example, in your face. So it varies between one individual and another. It also varies between body regions. Now let's talk about the epidermis itself. Structurally, this is how the epidermis would look like. We have already indicated that the layer of epithelium. In our earlier discussion of epithelial tissues, told you that when you want to classify epithelium, you look at three things. The first one is you look at how many cell layers do we see. And here we see many cell layers, so we call it stratified as opposed to simple. The second concept, you look at the shape of the cells that are near the surface. And the cells here appear flattened, so we use the term squamous as opposed to cuboidal or columnar. So this is stratified squamous epithelium. We indicated that when you have stratified squamous epithelium, this epithelium is very adapted to abrasion forces. It is adapted to withstand friction. And there are three varieties of stratified squamous epithelium based on the degree of exposure to friction. As with regard to the epidermis, which is the one that is exposed to most friction, the epidermis has another layer on top of it, a layer of keratin. And so this variant of stratified squamous epithelium is simply known as stratified squamous keratinized epithelium. I hope you remember the other two variants of stratified squamous epithelium. So epidermis is stratified squamous keratinized epithelium. Based on the structure of the epidermis, we can classify skin into two histological types. Remember, this is based on the structure of the epidermis. It is not based on the full thickness of the skin, which means you are looking at dermis and hypodermis. Sorry, dermis and epidermis, no. Here, we're just looking at the epidermis. So based on the structure of the epidermis, we have two types of skin. There's a type of skin that has a very thick keratin layer. As you can see in your left-hand side, the keratin layer is even thicker than the cellular layer. Very thick. This type of epidermis, this type of skin is called the glabrous skin. You can call it thick skin. This type of skin usually lack hair. It has very thick epidermis, yes, it has very thick keratin layer and does not have hair. It is the type of skin that you find in the palm of the hand and the sole of the foot. Compare that with the one on your right-hand side, which we call thin skin. So if you look, you note that the keratin layer is not very thick and not very compact. This type of skin is the one that will be having hair. Well, it doesn't have to be amount of hair you see in your scalp. It can still be just this fine hair that you find maybe even in your face or in your forearm. If you look carefully, you'll see some hair. So that is what we call thin skin. Again, I repeat, this classification is not based on the full thickness of the skin. Because if you are to base it on full thickness of the skin, then we know that the thickest of skin is actually the skin of the back. It is the thickest skin in the body, but it's still considered thin skin because of the structure of the epidermis. There are a number of cell types in the epidermis. I will highlight 4 for you. In order of the abundance, the most abundant of them are the ones we call the keratinocytes. The keratinocytes are found in all the zones of the epidermis. We'll be looking at the zones of the epidermis shortly. Keratinocytes are present in all the epidermal zones. They're the ones that form the protective barrier. Basically, we talked about skin having protection as a role. These are the ones that form the protective barrier. Apart from forming the protective barrier, keratinocytes are actually the ones that secrete the keratin pigment. The keratin substance. It's a protein. It's not a pigment, it's a protein. It is for this reason that we call them keratinocytes. Usually they have some granules within them, known as keratohyalin granules. These keratohyalin granules are the ones that eventually, when the cell dies, become keratin. So keratin is a cellular material. If you remember from our lecture series on cytology, keratin is an intermediate filament that is found in epithelial tissues. The second most abundant of the cell type are known as melanocytes. The melanocytes of the skin are the ones that secrete the skin pigment. The pigment is called melanin that help in absorption of UV light. You might not believe this, but the amount of melanocytes, the number of melanocytes is fairly constant within human beings. What varies perhaps is the activity of the melanocytes. So if you are dark, maybe just your melanocytes are a bit happier than those who are light, where their melanocytes are a bit lazy. But that's okay. The number of melanocytes are the same in humans. The third most abundant of the cell types are the Langerhans cells of the skin. The Langerhans cells of the skin are skin macrophages. They are cells that fight infections by engulfing them and presenting them to other white blood cells. You know that the T lymphocytes are the ones that are involved in cellular immunity. And so Langerhans cells engulf and present them to T lymphocytes, the ones which are involved in cellular immunity. Lastly, we have the Merkel cells. The Merkel cells are tactile receptor cells. So they have some nerve terminals which convey signals from the skin for mechanoreception. They are mechanoreceptor cells. They are the least abundant from what I've given you. Let's talk about the structure, the strata or the layers of the epidermis. The epidermis is in layers. Look at the image on your left. You see this keratin layer. Then this is the cellular layer. You can see the epidermal ridges and the dermal papilla, the interdigitations. Let's take this cellular layer and magnify it. We put it here. So down here is the dermis. Then from here, that way is perhaps this region there. So for some reason, we name the layers of the epidermis from the deepest to superficial. I don't know why, but let's continue with that. The first layer of the epidermis, which means the deepest layer of the epidermis, the layer of the epidermis next to the dermis, is known as the basal layer. You can call it in Latin stratum basale to mean the basal layer, or stratum germinativum to mean the germinating layer. This is the layer of cell division. It is a layer that contains the stem cells responsible for regeneration of skin epithelial cells. Within this layer, we have the melanocytes as well. The melanocytes are in this basal layer. Then you have the stratum spinosum, which is the largest cellular layer. The stratum spinosum contains cells with spines. It's for that reason that we get the name spinosum. We know that the cells in the stratum spinosum also have ability for mitotic activity, although not as much as the ones in the stratum basale. In high school, these two layers are the ones we call the Malpighian layer. Those days. The third cellular layer of the epidermis is this zone here that seems to contain cells with granules, and for that reason we call it stratum granulosum. This is the layer that contains the squamous cells. For that reason we call the skin the epidermis stratified squamous. Stratum granulosum contains the keratohyalin granules, which later form the keratin. We have a layer called stratum lucidum. The stratum lucidum is only present in the glabrous skin. We only see it in the glabrous skin. We don't see it in the thin skin. It's a region that we believe is responsible for protection against fluid loss in those regions which are not occupied by hair. That's why it applies to glabrous skin. Lastly, we have the stratum corneum. This is what we called in high school the conified layer. The stratum corneum is the region of the epidermis that contains dead material, keratin. It is acellular. It doesn't have cells. It just contains dead material, which we call keratin. Now, because of the stratification and because of the conification, the skin is well adapted to withstand friction. I want to mention something called epidermal melanin unit. The epidermal melanin unit refers to one melanocyte and all the keratinocytes that it distributes its melanin pigment to. So the understanding is that the melanocytes are found on the stratum basale. They produce melanin pigment, But this melanin pigment is distributed to a number of keratinocytes, usually in the range of 50 keratinocytes. So melanocytes have processes that distribute the melanin pigment to many surrounding keratinocytes. It is for this reason that sometimes when we stain the epidermis, the melanocytes, in as much as they're the ones which are pigment cells, paradoxically, they don't show the pigment. They're the ones that appear clear on light microscopy because their pigment is distributed to the keratinocytes. So the keratinocytes are the ones that take stain because of that pigment picking the stain. But the melanocytes paradoxically don't stain because it distributes its pigment to the surrounding keratinocytes. So I told you earlier that generally the epidermal melanin units are relatively constant among human beings. What varies is the activity of the melanocytes. We now talk about the structure of the dermis. The dermis is a connective tissue layer, as we indicated earlier, as opposed to epithelial layer of the epidermis. Because it's a connective tissue layer, its primary role is to provide strength to skin. There are two parts of the dermis. The part of the dermis that extend into the epidermis are the ones we have just called the papillary dermis or the dermal papillae. These dermal papilla are made up of loose connective tissue. Loose connective tissue. I hope you remember that from our lecture series on connective tissue biology. The loose connective tissue of the papillary dermis tends to contain in some regions some sensory receptor cells, some sensory receptors which we called the Meissner's corpuscles. The rest of the dermis is what we call the reticular dermis. Reticular dermis consists of dense, irregular connective tissue as opposed to loose connective tissue of the papillary dermis. This dense, irregular connective tissue of the reticular dermis, as the name suggests, means that the collagen fibers are closely packed, hence dense, and that they are running in different directions, hence irregular. The reticular dermis contain, other than just dense, irregular connective tissue, it contains other things, like the sweat glands will be there, the hair follicles extend there, and the like. The sensory receptors are also found within it. We are going to talk about the glands which are found in the dermis, but let's first talk about the cutaneous sensory receptors which are found in the dermis. We have looked at cutaneous receptors before, but for completion's sake, let's mention some three of them which I want to emphasize on. One of the cutaneous receptors on the skin are the free nerve endings. Usually these ones are nerve endings that do not have myelin around them. And also they don't have connective tissue around them. So it's just a free nerve ending, as the name suggests. The free nerve endings terminate in the stratum granulosum of the epidermis. They would look like this, or perhaps like this in an actual slide. These free nerve endings are receptors for light touch, for heat, for cold, and for pain. So there are nociceptors, there are thermoreceptors, and there are tactile receptors. The second type are these ones, which, as you can see, looking like an onion bulb. We call this the Pacinian corpuscle. Structurally, Pacinian corpuscles have a capsule around them, so they are encapsulated receptors. They have a very thick connective tissue capsule around. Then within it consists of lamellae of connective tissue, concentric lamellae of connective tissue. Pacinian corpuscles detect pressure changes as well as vibration changes which are applied to the skin surface. So they could be in a group like these ones or just single, but generally understand that they are encapsulated and they have concentric lamellae of connective tissue within. Pacinian corpuscles are located in the dermis as well as hypodermis. And that's why in our earlier lecture, we classify them under deep receptors. The third one I want to talk about are the Meissner's corpuscles. Meissner's corpuscles are located in the papillary dermis, as I told you. They are also encapsulated. They have a capsule around, they are encapsulated. Located in the papillary dermis, Meissner's corpuscles are receptors for light touch. Many other receptors we mentioned, like the Krauss end bulb, Merkel's disc, Ruffini terminals, and nerve plexus around hair follicles. And I remember giving you an assignment to go check on what they do. The assignment still stands. Okay, let's finish the first part of the lecture by talking about microscopic organization of some 3 types of glands. We'll start with the sweat glands. So sweat glands are usually simple tubular coiled glands. The term simple means that the gland is not branching, but they are usually coiled. And that's why in cross-section, they'll appear like tubular structures which have been cut in cross-section. These are sweat glands. They have secretory portion as well as the ductal portion. The ductal portions are these ones which are crossing the dermis to go to the epidermis. The secretory portions are these ones which have been cut in cross-section. The secretory portion of sweat glands can be within the dermis or the junction between the dermis and the hypodermis. So this is how the secretory portions would look like. They are highly coiled. The portions are the ones which cross the dermis and the epidermis. There are 2 types of sweat glands. This is what we call the eccrine type of sweat glands. The eccrine type of sweat glands are the ones that open directly onto the surface of the epidermis, the surface of the skin. This type of sweat glands are the majority. They produce watery sweat, serous secretion, direct onto the skin surface. They are found all over the body, and they are the ones responsible for thermoregulation. But there's a second type of sweat glands, the one in blue, which we call the apocrine type of sweat glands. These types of sweat glands are fewer and uniquely see how they drain. The duct of apocrine sweat glands open along hair follicle as opposed to directly onto the skin surface. These types of sweat glands have a mucoid secretion. Their secretions are a bit thicker. They are not found all over the body. We find them in the axillary region, that means your armpits, the pubic region, you know, the 1%, and maybe a few other areas like the external auditory meatus of the ear, and perhaps some places in the eyelid. In humans, they are a bit rudimentary, but we know that the secretions of the apocrine sweat glands can be very unique once they have been acted upon by bacteria. The smell from them can be very characteristic of individuals. When someone passes near you, you know that that is so and so who has passed because of this type of odor that they produce. Well, this is the era of perfumes, and so perhaps you might not be very familiar with that concept. So apart from sweat glands, we also have the sebaceous glands. The sebaceous glands exist as a unit. The unit is known as the pilosebaceous unit. Pilosebaceous unit consists of 3 components. We have the sebaceous glands. These are the sebaceous glands. They are holocrine glands. A holocrine gland is a gland that disquamates. It disintegrates, the cell disintegrates when the secretions are being released. So the sebaceous glands will be highly mitotic, because for sebaceous glands to release their secretions, it means that the whole cell dies. So they are highly mitotic for that reason. They are holocrine glands. Their secretions is sebum. You can check the role of sebum. They coexist together with the hair follicle and what we call erector pili muscle, this one. And that's why now that conglomerate of 3 things is known as the pilosebaceous unit. The erector pili muscle is this one, the one that makes hair to stand, the muscle that contracts to make hair to stand. So the understanding is that the contraction of the erector pili muscle helps to squeeze the components of the sebaceous gland so that it can now release its secretions along hair follicle. Having mentioned that the cells must disintegrate when the secretions are being released, so they need some external pressure to ensure the disintegration of the cells, and that pressure is provided by the erector pili muscle. The last gland I want to talk about is the breast. We will talk about the female breast and not the male breast, because the female breast is more interesting to talk about, and there's nothing much to say about the male breast, but yeah, males also have breast. The female breast is located in the anterior chest wall. Usually there's a potential space that separates the breast tissue from the muscles. That potential space is what we call the retromammary space. The base of the breast is broader than the apex of the breast. So what are the extents of the breast? You know, based on shape, we can talk about where the apex is found. But the base of the breast extends from above the 2nd rib to the 6th rib below, and from medially the lateral border to laterally the mid-axillary line. This region here is what we call the nipple areolar complex. The areola is the hyperpigmented region around the nipple, and the nipple is the projection. The nipple in particular is located around the mid-clavicular line, the line through the middle of the clavicle, and the 4th intercostal space, along the 4th intercostal space. We can divide the breast into quadrants. So by using one vertical line and one horizontal line through the nipple, we have the upper outer quadrant, upper inner quadrant, lower inner quadrant, and lower outer quadrant. Important to mention is that the upper outer quadrant has extensions of breast tissue towards the armpit, towards the axilla. The extension of breast tissue towards the axilla is what we know as we call the axillary tail of the breast. The person who discovered it is called Spence, and so it's sometimes called the tail of Spence. Okay, in terms of histological structure, I've told you that the breast is structurally dynamic, which means that it's difficult to talk about what's the normal size of the breast, how should the breast fall, what's the normal texture. Structurally dynamic, and all of them are normal. In as much as structurally dynamic, in terms of depending on many things, it can depend on age. The breast of someone who is a lady who is 15 years old will be different from the structure of breast of a woman who is 35 years old, and definitely different from that one who is 65 years old. It also depends on whether this breast has ever lactated or not. Maybe this woman is 35 years, but she's never breastfed. But this other woman is 35 years and she's breastfed. And I'm talking about breastfeeding the baby, not the other person. And even in terms of breastfeeding, you could be 35 years old and you've only breastfed once. And another one could be 35 years old and she has 10 children. The structure of the breast will be very different. So it is structurally dynamic. Also, you could be of the same age, the same number of children, same exposure to breastfeeding, but genetically, you come from different places. And so you will see one having a bigger breast compared to another one. I'm just emphasizing the fact that the breast is structurally dynamic and it is all acceptable. As a woman, you can go check your breast as well. And you'll find that one breast is slightly bigger than the other one. Again, that one is still normal. So don't start wondering, what is happening? Of course, there's some variation of size that now become pathological. Even though we are talking about structural diversity of the breast, there's some things which are universal. Each breast has about 15 to 20 lobes. And these were the ones representing the lobes. Each lobe consists of even smaller lobules, what we call the ductolobular units of the breast. They are smaller lobules of the breast. Now, a lobe of the breast is drained by a duct. The duct that drains breast tissue is known as lactiferous duct. So the lactiferous ducts are many. We'd expect about 15 to 20 in total, because we are talking about 15 to 20 lobes. All the lactiferous ducts drain towards the nipple independently. And that means, again, we expect about 15 to 20 openings at the nipple, not just one big opening, but multiple openings. The parenchyma of the breast, and when I talk about parenchyma, I'm referring to the functional component, the epithelial component, as opposed to the connective tissue components, which we'll call the stroma of the breast. The breast parenchyma has three important types of cells. We have the lobular cell. These are the cells which form milk. They're the ones in the lobules. They form milk. They are the secretory cells. We have the ductal cells, the cells which are along the ducts, the lactiferous ducts. And you have myoepithelial cells, the cells which contract to squeeze milk out of the lobules. The myoepithelial cells are the ones which are targeted by oxytocin hormone, while the lobular cells are the ones which are targeted by the prolactin hormone. I am mentioning these different types of cells because of this era of breast cancers, and these are the terminologies you might hear from histological point of view when they classify breast tumors into some histological types. It is important then at this point also to talk about the lymphatic drain of the breast because of its clinical significance. The breast has a very rich lymphatic drainage. The lymphs which come from the breast drain into multiple lymph nodes, but two of the lymph node groups are worth highlighting. The lymph nodes which are within the axilla are the ones we call the axillary lymph nodes. They drain about 75% of breast lymphatics. So they're found within the axilla, within the armpit. Then the lymph nodes which are on either side of the sternum, the parasternal lymph nodes, you can call them internal mammary nodes. The internal mammary nodes drain about 20% of breast lymphatics. I want to mention to you that breast lymphatics can also drain between one breast and another. So the left breast can take its lymphatic to the right breast and vice versa. Why am I telling you more about lymphatic drainage? Because the lymphs of the breast are primarily responsible for metastatic breast disease. The spread of breast cancer largely rely on lymphatic spread of the cancer cells. And having mentioned that the axilla receives about 3/4 of the breast lymphatics, the axilla is the first place to check if a patient is suspected to have breast cancer and you want to determine whether there is spread. But also to mention that if the left breast has gotten breast cancer, the right breast is also at higher risk because of the possibility of the intermammary spread. Right, so, okay, this image shows you the lymphatics. On that note, you might have heard of the sentinel node. The sentinel node is the axillary lymph node that is believed to be the first one to receive all the breast lymphatics. If that is possible, then we can clinically apply that information by sometimes just mapping whether the sentinel node is involved in cancer spread. We call that concept sentinel node mapping. And we can map sentinel node. You know, if a woman has breast cancer, you've already diagnosed this and you want to now initiate therapy, maybe surgery. You want to know, should I remove the breast together with the axillary lymph nodes, or should I spare the axillary lymph nodes? There are pros and cons of that. The pros is that at least if you remove the axillary lymph nodes, in case the cancer is spread there, it will be removed, and that's a pro. The con is that once you remove the lymph nodes in the axilla, you know, the upper limb also relies on those lymphatics. So this woman will be having a lot of lymphedema because you'll have destroyed how lymph from the upper limb also goes. So that's more of a morbidity. And so for us to remove the axillary lymph nodes, we need some scientific justification for removing them. That's why we do sentinel node mapping. If you map the sentinel node and you are able to remove that sentinel node, you can biopsy the sentinel node and find out whether it has tumor cells. If the sentinel node has tumor cells, then it most likely the axillary nodes are involved. In that case, remove the axillary nodes. But if you do sentinel node biopsy and you find that clear of tumor cells, we can make a good assumption, a safe assumption. And remember, it's an assumption. We can make an assumption that the breast lymphatics have not particularly spread the axillary lymph nodes, and that means that we can spare the axillary lymph nodes during surgery. Not 100% on either way, but just some scientific ways of guiding therapy. So I think that marks the end of the first part of the lecture. I want to give you a short break before we continue with the second part. But if you have a question, feel free to ask. So in this second part, we are going to look at behavioral and physiological mechanisms of thermoregulation. We will focus in particular on the following. So first, we'll state the normal body temperature. And we are going to state also the normal physiological variations to the body temperature. We will then look at the mechanisms that regulate the body temperature by classifying them into some 3 categories. One of those categories is the hypothalamic mechanism. So that one in particular will dig deeper by looking at the mechanisms initiated by the hypothalamus to regulate body temperature. And in specific, we are going to look at how the body responds to cold. We're also going to look at how the body responds to heat. And because we are clinicians, we are going to talk about the physiology, or let me say the pathophysiology, because not a normal process, the pathophysiology of fever. Let's start with the first agenda, the normal body temperature. You know, in this era of Corona, it has taught us a lot about body temperature. You go to every building and your body temperature is being taken. I was, however, fascinated by a particular restaurant I went to. And as I was entering, the watchman first stopped me arrogantly that I need to check my body temperature. So I complied. I had not seen him, not that I was walking away, but he just didn't call me nicely to go check the body temperature. So anyway, I complied without arguing much and went to check my body temperature. He's the one who was doing it. So he took it and the reading was 39. And I didn't say anything to me. So I was a little worried. And I said, should I just keep quiet? Then I said, no, let me initiate the conversation. So I asked him, are you worried that my body temperature is 39? Then he told me it's normal, that that's okay. So my wife also took and she was 38.7. I'm like, ah, is that normal? He was like, yeah, that's fine, that's fine. So I realized that in as much as some of the watchmen are being told to take body temperature, they might not know what it actually means for it to be normal or abnormal. Well, this one in particular, I was so sure I was not sick. So I was sure I wasn't sick. It was more about the thermometer having an issue. Or maybe it was taking the environmental temperature. I'm not so sure. It was very sunny that day anyway. But I was just wondering, sometimes some of these things we do, if you don't have an understanding what you do, you'll just be a robot. The normal body temperature is about 36.0 to 37.5. Although I've seen readings of 35 point something, and they're still considered normal, depending on really the environmental temperature. There's some places where 35 point something is still considered normal. And I believe you've gone to some malls in a cold day, and perhaps your temperature is 35.6, and of course you aren't dead, that's why you are there. There's some physiological conditions which are known to make the body temperature vary. One of them is the circadian rhythm. Your body temperature when you wake up is lower than your body temperature in the evening, usually by around 0.6%, 0.6 degrees Celsius. And this is largely because during the day you are metabolically active, and so you generated some heat. Also, for women, the time of ovulation, your body temperature rises up a bit by about 0.5 degrees. Well, I don't know why that is why the time of ovulation is known as she's on heat. I am not so sure, but we know that during ovulation, the body temperature rises. The first trimester of pregnancy is also characterized by a slight elevation of body temperature. Children also have a slightly higher temperature than adults. And we know that during exercise, the body temperature can be so high. And 0.5 there is actually just an example, but the body temperature, especially the rectal temperature during exercise, can even reach 40 degrees during exercise. You can also add maybe environmental temperature here that affect body temperature. Okay, so what are the mechanisms that help to regulate the body temperature? There are three mechanisms that help to regulate body temperature. And here I'll invite you for some discussion. So there's what we call the voluntary behavioral mechanisms. This depends on what you do. Intentionally, you make a decision. They are voluntary. What do you do when it is very cold? And what do you do when it is very hot? Remember, these are voluntary decisions you make as an individual to lower the body temperature or to raise the body temperature depending on the situation. So this one I want to give you an opportunity to discuss amongst yourselves. What are some of these voluntary behavioral mechanisms of thermoregulation? So you're going to answer two things. You're going to answer, how do you voluntarily behave when it is very cold? In other words, response to cold. And what are some of the voluntary behavioral mechanisms in response to high temperature? I'll break you down into groups, and I'll give you perhaps 3 minutes to discuss this. So you'll be into 3 groups. Okay, I've given you 4 minutes, after which I'll call you back. So just accept your group and discuss that question. 4 minutes. So the second mechanism, apart from voluntary behavioral mechanism, the second mechanism are what we call local skin temperature reflexes. These ones apply to changes on the skin temperature that are not generalized. For example, if you just hold a cube of ice, the whole body temperature does not change, but there's a temperature change at that position where the cube of ice is. So there's some mechanisms that mediate regulation of temperature at local areas of the skin. So these are the ones we are calling local skin temperature reflexes. So they involve vasoconstriction and vasodilation of skin blood vessels. In response to cold, we have cutaneous vasoconstriction. And in response to heat, we have cutaneous vasodilation. Remember, this vasoconstriction and vasodilation are localized. So it's not the whole body undergoing vasoconstriction or vasodilation, just the region of the skin that is affected by the temperature alteration. The third mechanism is what we call hypothalamic mechanisms. Now, these are the ones I want us to talk about. And so that brings us to our third agenda, which is to talk about the mechanisms that hypothalamus utilizes to regulate body temperature. Now, it is important for us to know that the hypothalamus regulates the body temperature around what we call a set point temperature. The set point temperature is 37.0 degrees. So the hypothalamus regulates our body temperature around that point, which means that when the temperature is high, hypothalamus will initiate mechanisms that lower it to 37. And if the temperature is lower than 37.0, hypothalamus initiates mechanisms that raise the body temperature to 37. And I'm not saying that the low or the high is abnormal. It could just be 37.3. It is still physiologically normal, except it's above the set point temperature. So hypothalamus will slowly initiate mechanisms that make sure that this body temperature goes to 37. And if it is low, maybe it is just 36.5, which is normal. Hypothalamus will initiate mechanisms that ensure that temperature goes to 37. So that's why I'm saying the 37.0 is a set point temperature. Now, for the hypothalamus to do this, it will rely on input from the receptors for temperature. The thermoreceptors are there. They're the ones that detect body temperature. And so it will rely on the information coming in from the receptors. What is the body temperature from those receptors? It is comparing with the set point temperature within it, then making that decision. The types of thermoreceptors can be classified into two, the peripheral and the central ones. The peripheral thermoreceptors are the ones largely on the skin surface. So predominantly picking the temperature of the skin. Then we have the central thermoreceptors, which detect the temperature of blood. The temperature of the blood is largely detected by hypothalamus itself. So whether the information coming in is telling the hypothalamus that it's too cold or it's too hot, whatever it is, hypothalamus provide responses. Responses which go to various effectors with the aim of restoring the 37.0 and maintaining it there. So let's see what happens We are saying we have thermoreceptors, which can be detecting the temperature of skin, but also detecting the temperature of blood. The ones detecting the temperature of skin are peripheral thermoreceptors. The ones detecting the temperature of blood are central thermoreceptors. The thermoreceptors take the information to the hypothalamus. These are centers within the hypothalamus that regulate the body temperature. So if the information going in through the thermoreceptors is different from the set point temperature in the hypothalamus will initiate mechanisms that restore that temperature to 37.0. These mechanisms that hypothalamus initiates will be targeting some key effector organs. One of them are the blood vessels on the skin. They are a target. We also have the arrector pili muscles of the skin. They're also a target. Sweat glands on the skin are also a target. Skeletal muscles are targets. And lastly, the adrenal and the thyroid glands are also targets. I want you to think through how these targets will respond in response to heat and in response to cold. But basically, these are the 5 effector organs that the hypothalamus relies on to restore body temperature, depending on that actual body temperature. So that brings me then to the normal physiological response to cold. So if you have cold, what will be the body's response? So first of all, we will have the normal behavioral responses, which we've talked about. You can decide to take a hot drink. You can decide to wear warm clothing. You can decide to remain indoors as opposed to outdoors. You can decide to close the windows of your house. You can decide to warm the house. You can decide to do some exercise just to make sure that you feel warm. So whatever you do, you can decide not to leave your blanket. And if you are too, you can decide to do other things as well. So basically, those are behavioral responses. But there's a way also that hypothalamus helps in terms of cold. What are some of the regulatory mechanisms that hypothalamus initiates in response to cold? 2 things hypothalamus will do. Hypothalamus will initiate mechanisms of heat conservation. The little heat that is already in the body should not go away when it is cold. The heat that is already within the body should not go away. Those are heat conservation mechanisms. Other than that, hypothalamus will also initiate mechanisms that help you to generate extra heat. Those are mechanisms of heat gain, mechanisms of thermogenesis. These 2 broad umbrella of mechanisms operate using those 5 target organs. So let's see which target organs are actually aiming at conserving the little heat that is within the body. The cutaneous blood vessels are one of them. In response to cold, we will have cutaneous vasoconstriction, so that the little heat that is within there does not go away. The other target are the arrector pili muscles. In response to cold, the arrector pili muscles contract so that the hair on the skin stands. We call that piloerection. This one conserves heat. Lastly, the sweat glands are also a target, but in this case, there'll be no sweating. The sweating is reduced so that you don't lose the heat that you do have. These are mechanisms of heat conservation. Now, hypothalamus is very bright. In addition to just reducing heat loss, it also initiates mechanisms of generating extra heat. These ones target now the skeletal muscles. The skeletal muscles respond by shivering. This is the involuntary contraction of skeletal muscles so that you can generate metabolic heat. Lastly, the adrenal glands and the thyroid gland is also a target. These glands produce their hormones. The hormones from adrenal gland are the catecholamines. The hormones from thyroid gland are the thyroid hormones, T3, T4. The role of these hormones is to increase the basal metabolic rate. So basically, the hormones are secreted to increase metabolism. These hormones usually increase metabolism. And through that, we will have heat generation. So this is the hypothalamic response to cold. How about the normal physiological response to heat? So again, for response to heat, we will have the behavioral mechanisms as well as having the hypothalamic mechanisms. The behavioral mechanisms in response to heat will include things like taking that cold drink that you told me, or opening the windows, putting on the fan, dressing less, you go to swim, and things like that. Or now going under a shade in a tree, something. Leaving your house, if the house is the issue, you go outdoors. So basically, those are behavioral mechanisms in response to heat. But we then have the hypothalamic mechanisms in response to heat. The hypothalamic mechanisms in response to heat will be twofold as well. In one way, hypothalamus initiates mechanisms that promote heat loss. The heat that is already in your body, that extra heat that is already in your body, shed it off. So that's one umbrella. But there's another umbrella to it. And this one is, don't add unnecessarily. We cannot stop heat gain because we are alive. Metabolism must go on because we are alive. But is it possible that you minimize the amount of heat you're gaining? Yes, it is possible. So these are the two umbrella mechanisms that hypothalamus will use in response to high temperature. So again, the target organs for mechanisms of promoting heat loss will be similar to the target organs of mechanisms of conserving heat. For the blood vessels, there'll be vasodilation so that you shed off extra heat. For the muscles on the skin, there'll be pilorelaxation so that the hair falls down. And if the hair falls down, it means therefore that we don't put a coat on your skin to conserve heat. And then there'll be increased sweating so that you lose heat. Mechanisms of heat gain are those ones that make skeletal muscles to contract and the adrenal glands to produce their hormones to increase metabolism. Now, to minimize that, there'll be no shivering from skeletal muscles, and there'll be less hormonal secretion from those two endocrine glands, so that we don't add heat unnecessarily. Those are the hypothalamic mechanisms geared towards addressing high body temperature. Let's finish with the pathophysiology of fever. So perhaps we need a definition of fever. I believe all of you are practicing, and so you know what fever is. Abnormally high body temperature, although the patient is complaining of cold. So, you know, if you're feeling hot and the body is hot, you don't call that fever. But we call it fever when it's pathologically high, yet the patient is complaining of cold. Let's think through how it comes about. I'll use a graph to help us explain the pathophysiology of fever. Let's take the vertical to represent the body temperature in degrees Celsius, and the horizontal to represent time. We have indicated that the hypothalamic set point temperature is usually 37.0. So that's the normal set point temperature. We've also indicated that the hypothalamus then works around that to maintain the body temperature around it. So the thick dotted lines represent the actual body temperature in a normal scenario. It will be revolving around 37.0. It could be 36.8 or 37.2. That is physiologically normal. Now, sometimes then we may get an infection. Infections that cause fever are called pyrogenic infections. So this infection, what they do is this. You see this thing here, the 37.0 set point temperature. Those infections, because of the things they cause to be released in your body, those cytokines reset the set point temperature in the hypothalamus to a higher level. For the sake of this discussion, we can say that the infection has reset the body temperature, the set point temperature to 40 degrees. It could be 38, it could be 39. It could be 40 or higher. So let's assume that you've gotten that plasmodium infection. And yes, there are molecular changes within your body by release of some cytokines. The end result is what? That now your body, the set point temperature in the hypothalamus is no longer 37.0, but 40.0. So your actual body temperature is 37.0, but the set point temperature is 40. What will the body feel? The hypothalamus is telling the body that the temperature is too low. Because it's comparing 40 with 37, that body temperature is too low. So what happens? It will initiate mechanisms in response to cold. Both behavioral will apply, as well as the hypothalamic mechanisms will apply. Now think through those mechanisms. For behavioral, that's when you take your blankets, you even take your jirani, and so like things, you can put on very heavy clothing, things like that. The behavioral one will apply, as well as the hypothalamic mechanisms will apply. When that happens, we call this phase of fever the chills stage of fever. The chill stage of fever is characterized by shivering. The person is saying, I'm feeling cold, yet the body temperature is actually rising. See, there's a time that the body temperature could be 38. That's a high temperature, to be honest, but the person is still saying, I'm feeling very cold, because it is lower than 40. It could be 39. The person is still saying, I'm feeling cold. It is until that body temperature reaches the abnormally reset temperature that the person will now feel better. Let's assume that lasts for some time. But in the course of events, you realize, this person is actually sick for some reason. So usually what we do when you discover that, maybe they have gone to hospital or self-medication, we administer paracetamol. What exactly does paracetamol do? Paracetamol actually resets the abnormally set point temperature. It resets it to the normal one. So yes, it was abnormally reset at 40. Now paracetamol returns the set point temperature in the hypothalamus to 37.0. The paracetamol does not really lower the body temperature. It just resets the normal set point temperature. When that happens, now the body takes over. So your paracetamol has reset the set point temperature to 37.0. The actual body temperature is 40. What will the person feel? I am burning. What will they do? They'll start behavioral mechanisms of heat loss, response to heat. But hypothalamus will also take over the mechanisms of heat loss, as well as mechanisms of minimizing heat gain. So this period of fever is characterized by a lot of sweating, and we call it the crisis stage of fever, until that actual body temperature reaches the reset point temperature. All right, so that is basically the pathophysiology of fever. I don't know whether you have a question with regard to thermoregulation. I can give you a few minutes to ask, then we proceed with development and congenital anomalies of the integument system. So we are now going to look at development and congenital anomalies of the skin and its appendages. Our intention, we will not talk about number 1 because we've already talked about that just a few minutes ago, so not a big deal, but we'll talk about number 2, embryonic origins of the skin and its appendages. We'll talk about development of the epidermis and the dermis. We'll talk about development of the sweat glands and mammary glands, and we'll talk about unique features of the developing skin, and we'll finish with congenital anomalies of the integument system. So let's go straight to object number 2, because object number 1 is still fresh in our mind, so I've skipped it. The skin has different embryonic origins. The dermis has a different embryonic origin compared to the epidermis. The epidermis of the skin, and specifically the keratinocytes of the skin, arise from surface ectoderm. I hope you remember this thing of ectoderm, mesoderm, endoderm, and that the ectoderm underwent neurulation, the central part to form the neurotube. The other part of the ectoderm is the surface ectoderm. The surface ectoderm becomes the epidermis of the skin, and specifically giving rise to the keratinocytes. The dermis of the skin come from mesoderm. This mesoderm is this one here. It gives rise to the dermis of the skin. Well, mesoderm also gives you the Langerhans cells of the epidermis. Neurocrest cells also have a role. Now look at this. Usually the surface ectoderm is on top, so that will give you the epidermis, and the mesoderm is usually beneath, that will give you the dermis. Neurocrest cells also have a role. The neurocrest cells give rise to melanocytes of the skin, which are also cells of the epidermis, as well as the Merkel cells of the skin, the mechanoreceptor cells of the skin. So specifically, let's look at how the epidermis and the dermis develops. We will start the development of the epidermis. The epidermis is initially covered by a single layer of ectodermal cells, which we call the surface ectoderm. Then as time goes by, this single layer of epidermal cells divides into two. An upper layer of flattened cells, we call that periderm, and a lower layer of cuboidal cells, which we call the basal layer. This basal layer is the layer that is responsible for giving rise to the stem cells. Eventually, it is the one that becomes the stratum basale, while the cells which are being formed migrate to go on superficial zones of the epidermis. So as time goes by, we will not just have two layers, but multiple layers of the epidermis, according to those different strata that we talked about. So that happens progressively. Initially, you just had one layer, then two layers, then pole, we develop several layers. It will even reach a point where you even have the keratin layer. And usually the cells of the epidermis continue to desquamate into the amniotic fluid. So that is the story of the epidermis. The many layers come later on. How about the dermis? So dermis, it's a connective tissue layer. So initially, this is mesenchymal. I hope you remember what mesenchyme is, the primitive embryonic connective tissue. So the mesenchyme that give you the dermis of the skin has multiple sources. It may come from paraxial mesoderm. And the mesenchyme from the paraxial mesoderm is the one we called dermatome. That one gives you the dermis of the skin of the back. This mesenchyme may also come from somatic mesoderm. Remember, this is paraxial mesoderm, and then this is somatic mesoderm. The mesenchyme from somatic mesoderm will form the dermis of the skin of the lateral body wall, as well as the dermis of the skin within the limbs. And lastly, we also have mesenchyme that come from neurocrest. The mesenchyme that come from neurocrest form the dermis of the skin of the face. So I'm just saying that the dermis arises from mesenchyme, but that mesenchyme has multiple embryonic sources, unlike epidermis, which just come from surface ectoderm. How do the glands develop? Sweat glands develop as downgrowth from the surface ectoderm. So they develop as downgrowths, like what you see here. So initially just a bud appears, which continues and then canalizes and then undergo that coiling. That is how the sweat glands develop. And a similar concept for the breast as well, except I want to say more here. For breast development to take place, initially there's a band-like thickening that appears from the base of the upper limb to the base of the lower limb of the fetus. This band-like thickening is a thickening of the epidermis. We call it the mammary line or milk line or mammary ridge or milk ridge. Remember, it's a thickening of the epidermis because the thickening of the ectoderm. It extends from the base of the upper limb to the base of the lower limb. This milk line represents the location of the future breast, the potential location of the future breast. Now we know that in humans, we don't want multiple breasts. We only want one breast. So in human, what happens is that every part of that milk line disappears except the one in the anterior chest wall. But in other animals like dogs, you know, they have a line of breast tissue. So for them, multiple sites will remain. But in humans, you only want one breast on one side and another on the other side. So the only parts that remain are the ones in the anterior chest wall. The rest usually disappear. So the story then remains the same as that for the sweat glands, that the part that remains, again, the tissues of the ectoderm or epidermis just grow down to the underlying mesoderm or mesenchyme in the manner shown in these images. So initially you have a bud, then the bud branches, as we can see here, down from the epidermis, remember. Then that bud, as it branches, it also develops some canals, and we can see in the last image, canalization has occurred, representing the different ducts. Important to note is that the upper part of the breast, where we expect the nipple, is initially just a depression, what we call the mammary pit. This mammary pit will eventually evert just before birth. So what are some of the unique features of the developing skin? We can say a number, but I think two are common, and so I want to highlight on them. One is lanugo hair. Lanugo hair is this fine miniature hair that is present in the fetus. This type of hair is very smooth, very fine, very soft. Unfortunately, it disappears. By around the time of birth, usually a large part of this hair has disappeared. So this hair is more in the fetal life, premature type, than in the mature type. By the time fetal maturity reaches, this type of hair has disappeared, although sometimes babies can be born with this hair. And indeed, prematurity, one of the markers of prematurity, the presence of lanugo hair. But some term babies may still have lanugo hair. There's something called vernix caseosa, which is just this whitish paste representing secretions of sebaceous gland and discoloration of the skin. This whitish paste is usually also present in the fetus. Then pole it disappears. As we approach term, the whitish paste will have disappeared. Again, you may still have persistence of the whitish paste in a term baby, and it's fine. But we also know that the presence of vernix caseosa could be a clinical indicator of prematurity. We expect to see it more in the premature babies. This whitish paste usually protect against the corrosive effects of the amniotic fluid. I will now finish with congenital anomalies of the integument system. I'll start with anomalies of pigmentation. So I'll highlight on two anomalies of pigmentation. The first one, where you have some patchy areas of depigmented skin. This is what we call vitiligo. It could be congenital, but mostly it is usually acquired. The acquired one could be just some autoimmune disorders that target melanocytes, some drug reactions, but it can also be congenital. Albinism is definitely congenital, usually autosomal recessive disorder. The main thing with albinism is an enzyme deficiency, tyrosinase. And usually because the enzyme is deficient, now the melanocytes cannot form that normal melanin pigment. Remember, the melanocytes are present in the basal layer of the epidermis. So that's where the enzyme tyrosinase also acts. This is albinism. We'll also talk about disorders. Okay, this is still a disorder of pigmentation. The one you're seeing there is still a disorder of pigmentation. We call this one melanocytic nevi. They're usually not as large as this one. I've just put this one to show how ugly it can be. But in most cases, they're just very tiny things. It could just be one spot like that tiny one until you're not even cognizant of it. And when you do, you even smile around it and say it's a birthmark. Melanocytic nevi represents regions of melanocyte arrest. The melanocytes were arrested before they reach the epidermis, so they're in the dermis, then they still produce the pigment. That's what gives you that kind of a picture. The one to your right seems to affect skin color, but it's not because of the melanocytes. This is because of blood vessels. We call them cavernous hemangiomas. The cavernous hemangiomas are abnormal proliferation of cutaneous capillaries. They're abnormal proliferation of cutaneous capillaries. It's a benign one. Benign abnormal proliferation of cutaneous capillaries. So they look this ugly, and in most cases, they'll be on one side of the face here, representing a particular syndrome. This particular person also has some malformations in her brain. It's a particular syndrome. Anyway, the simple term we give to the cutaneous manifestation of it is port wine stain. Port wine stain are just cutaneous hemangiomas on the face, cutaneous hemangiomas on the face. Let's talk about malformations of hair. Congenital anomalies that affect hair. You can have excess hair, and that's what we call hypertrichosis, excess hair growth. And in most cases, it's the abnormal hair where you don't want it to be. You know, you wish this was in your scalp, but no, it is on the face. Look, we don't call it Bushman, we call it hypertrichosis. The opposite can also happen where there is no hair at all in every part of the body, including those parts you're thinking about right now. So when we don't have hair at all, we call it atrichia. If this absence of hair is just referring to the scalp hair, then of course we call it alopecia. Alopecia can be congenital, but in most cases it's acquired, which means that the person was not born with it, but it later develops, and especially in men with age. Alopecia can also be total or can be partial. So we talk of alopecia totalis and alopecia partialis. The normal baldness is usually alopecia partialis. How about malformations that affect keratin? To your left, you see children with skin which look very scaly. We call this ichthyosis. It's usually an autosomal recessive disorder. Actually, recently I saw one that was born in one of the hostels in our country, actually just last week. So their skin look like that of reptiles. We call it ichthyosis. It is due to excess keratinization. You can have malformations that affect nail. So like this one, the nail has not formed. We call absence of nail anonychia. There are those malformations that affect the breast. Like here, we see extra nipple. You can call it polythelia. It means extra nipple. That means absence of the nipple is called athelia. And when you have extra nipple, you call it polythelia. If the nipple has breast tissue, then we'd prefer to call it polymastia, extra breast. When there is polymastia, in most cases, the extra breast will be towards the axilla rather than down. And it can be unilateral or bilateral, like in this woman, where it's bilateral. Unfortunately, it's difficult for women to pick when they have polymastia until their first pregnancy. So when they have their first pregnancy, that's when they feel some swelling in their axilla. And then when we image them, we realize it's actually breast tissue. It doesn't have to be as prominent as you might imagine. Sometimes just kidogo. Okay, you can also have congenital absence of the breast. Now, this is a woman, and this is not the back, this is the front, actually. She doesn't have breast. Could be part of a syndrome like Turner syndrome. That is a mastia. This one is a common one where the nipple is inverted. You just call it inverted nipple. Very common in our setup, actually. And you people knowing that you practice, I'm sure you know how to manage inverted nipple. Lastly, you may have men with breast. I had had to pick at birth because breast developments usually begin at puberty. You see, for this woman, you know it is there because even the nipples are not there at all. So it is athelia and amastia. But if the nipples were there, it would be difficult to know whether this breast will never develop. Similarly, men with gynecomastia, you only see it at puberty or after that. Difficult to see it before birth, but we still call it gynecomastia, male breast. Right, I think that should be it now. We are done with all the three components of the lecture. We've looked at microscopic organization of the skin and its appendages. We've looked at thermoregulation, and we've looked at development and congenital anomalies of the integument system. And so we are done with all the three parts. I now have stretched you, but we are good.